Thank you all for joining us for today's webinar, HPV Prevention and Treatment in Special Populations, HPV in Male Patients. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre and post test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You are also welcome to use the chat and question box to ask questions throughout the webinar, which our presenter will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of this survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as the follow-up evaluation, helps ARHP ensure that we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Craig Roberts, today's presenter. Craig Roberts is an epidemiologist and physician assistant with more than 30 years of clinical and research experience in public health and infectious disease. He holds an appointment as an emeritus clinical assistant professor at the University of Wisconsin-Madison, where he works as a manager and clinician in the Sexual Health Clinic at University Health Services. He is a past chair of the Sexual Health Coalition of the American College Health Association. An expert in sexually transmitted infections, he consults and lectures frequently on topics relating to college population health and infectious diseases of young adults. Craig's full bio is available on ARHP's webinar web pages. We are thrilled to have him with us today, and I will hand it over to him. Craig, you have the floor.
Great, and thank you, Jessica. Appreciate that kind introduction. First of all, I just wanted to welcome everyone and remind you that this is the first of actually 4 parts on HPV and special populations. So I hope you'll join us for the follow-up webinars, which I believe are scheduled next month, and including topic of HPV in sexual and gender minorities, HPV in adolescents, and then we'll wrap up with a panel discussion by all 3 presenters. So that really should be quite interesting to follow. So just our disclosures, this is the planning committee as well as the other presenters. Today we'll be talking about HPV. Sorry, I wanted to get back to those objectives for you briefly. I will be reviewing some of the updated epidemiology and data behind HPV. I'm going to assume that most of you at this point are fairly familiar with HPV as a disease and HPV vaccine, but we wanted to give you the latest updates and recommendations on the vaccine as well as screening, and this webinar in particular with a particular focus on men. So as many of you know, epidemiology of HPV is kind of interesting. It really is the most common sexually transmitted disease in the United States. And overall in the United States, based in 2008 estimates, which is really the best data we have, there are around 19 to 20 million new cases of sexually transmitted infections in the U.S. estimated to occur, and about 14 to 15 million of those are HPV. So HPV infections account for the vast, vast majority of sexually transmitted infections that occur in the United States every year. It's estimated that roughly the prevalence of HPV is roughly 79 million Americans who are currently infected with HPV. And as I mentioned, about 14 million new infections enter that pool every year, and then a certain number are also, because HPV is a transient infection, cases are falling out of that pool. One important thing to note about the epidemiology here is that this data is actually now somewhat dated because it really is baseline data from at the time of the introduction of the vaccine in 2006, 2007. Although this was published in 2013, we have some new data now indicating that the incidence and prevalence of HPV, especially in adolescents, is actually declining quite rapidly. So it'll be really interesting when this data is updated to see sort of where we are. It's a little premature to sort of know what's going on right now, but I'm looking forward to seeing some new figures in the next couple of years to update this sort of incidence and prevalence data. As is true with other sexually transmitted diseases, most HPV infections occur in adolescents and young adults, 15 to 24 years of age. About 50% of all sexually transmitted infections occur in that age group. What's also interesting is that about 20% of men have HPV detected generally in the anogenital area. That would include the penis, scrotum, groin, perineum, and perianal area. And if you look at that, the range is really, really dramatic depending on the study. So that there's been prevalence detected as high as 79%. But in typical populations, especially in good studies with a broad range of populations in the United States, the average is between 20 and 25% of men. So of young, particularly in most all of these studies were done in young adults. For example, in college students, a study in the University of Washington about 10 years ago, again pre-vaccine, found that about 25% of males were HPV positive in a genital site. And that's just people, sort of students in that case, walking off the street and being tested. It's a population-based study, not a clinic-based study. In the subgroup of men who have sex with men, the prevalence of anal HPV is much higher, as you might expect in people who have had practicing receptive anal intercourse. And so then the last bullet here, again, the prevalence, this is the most exciting data that I can think of to present to you, and I think it's really interesting to see again where this is going to go. So this is from there are 3 studies that have been published now reviewing this data. The most recent one was published this year in pediatrics, where they've noted now a 64% decrease in the prevalence of HPV types 6, 11, 16, and 18, the original quadrivalent vaccine coverage types among adolescent females in the United States. That represents a 34% decrease among the next older cohort of 24. So the NHANES, if you're not familiar with it, is a national health survey that's done every year it's a population-based survey, so it's very, very representative of the U.S. population, in this case adolescents. So these were DNA-based studies looking for the presence of the virus, genital virus in young women. Very powerful data showing that we actually are starting to make a difference with the vaccine, although we certainly have a long, long ways to go. And I'm not, there we go, sorry. There is a slight delay here with the slide transitions, which I will apologize for. So one of the big issues with HPV is, of course, its causes and associated with cancer. And so this is also new updated data from CDC, just published a couple months ago, with new estimates of HPV-associated and HPV-attributable cancers. And let me just clarify what those terms mean. So an HPV-associated cancer is a cancer that occurs at a site that is typically associated with HPV. Attributable to HPV means that in this data, in this study, the cancer was thought to be caused by HPV. So for example, not all throat and neck cancers are caused by HPV. There are some that are attributable and others that are not. But the figure really is now around 31,000 new cancers annually that are caused or attributable to HPV, distributed there as shown among both men and women. And it's important to recognize this is a fairly high cancer burden in the U.S. And people still die from HPV cancers, primarily cervical cancers, but also anal cancers in men, throat cancers in men. And it turns out to be about 25 deaths a day in the United States, 3,000 to 4,000 annually occurring from these cancers. So this is still a huge problem in the United States, particularly for throat and neck cancers, which we're learning more about all the time. The incidence of those cancers is actually increasing, while the incidence of cancers like cervical cancer in women are decreasing. This shows you some additional data about how those cancers are spread among the various sites. And again, the percent that are in the first column, they're attributable to any HPV type. The second column is the proportion that are attributable to HPV 16 or 18, which of course is in the vaccine. And then interesting, in this study, they also then were able to calculate the proportion that are attributable to the additional 5 HPV types that are now found in the 9-valent vaccine. And the additional contribution of that vaccine, of those 5 types, in terms of what kind of cancers they're going to prevent, additional proportion of cancers. So certainly what as you see here, and this is kind of again important to recognize, that particularly for head and neck cancers, oropharyngeal cancers, men, and these are primarily middle-aged men who are developing these HPV cancers. This is one of the fastest growing HPV cancers in the U.S. right now. And again, we'll be talking about anal cancer a little bit, particularly in men who have sex with men, but it's important to recognize that anal cancers are not exclusive to men who have sex with men. They occur in heterosexual men as well as in women, and certainly are more common among people who've had a history of receptive anal intercourse. The other important kind of component of this we wanted to talk about is what's called intersectionality. And so just as a way of introducing the topic, and keep this in mind, that everything we talk about is always based on context. HPV is not a uniform disease that affects everyone the same. Your risk for having HPV infection, and certainly your risk of whether you get immunized or not, really depends on a lot of other issues, particularly social and cultural factors. And in marginalized populations, particularly lesbian, gay, and transgender persons, the issues can be very difficult and very complicated. So keep that in mind, as although most of the data we have and the approach to vaccine is traditionally based on gender alone, recognize that there are these other factors, including race and ethnicity, gender expression, sexual orientation, and socioeconomic status, that really will contribute a lot to a person's risk for HPV disease, HPV cancer, and getting the vaccine. All right, let's go on and talk about HPV in males specifically. Just as an overview, one of the interesting things about the epidemiology of HPV is that, and this is true of studies worldwide, that the distribution of disease occurs over multiple decades and generations. So unlike most other STIs, and unlike HPV infection in women, which tends to be more prevalent in younger women, HPV in men tends to be much more uniform across the lifespan. Certainly we see a lot of HPV in young adult males, but it's not really something that's going to disappear as soon as you turn 25. Those age categories of 15 to 24 are set up primarily as statistical epidemiologic age groupings, but there's nothing magic about turning 25 that lets you get off the hook. And just like HPV and any other sites, cervical or other genital sites, recognize that HPV symptoms don't actually occur in most people. Most infections are asymptomatic, but there can be a very long lag time between the time of infection happening with HPV and the time of a complication developing, like a neoplasia or a dysplasia. Just like with the cervix, HPV in men can cause genital warts, and it can also cause cancer at any site that is infected, and that includes penile cancers, anal cancers, and throat cancers in particular. Any genital site or site of physical genital sexual contact is where warts can appear. Most commonly we see these on the shaft of the penis, but also on the other sites there on the scrotum and around the anus, the mouth, or the throat. For those of you in clinical practice, you'll probably agree when I tell you that probably 99% of the genital warts we see in men are on the penis and scrotum, and in MSM certainly around the anus. Warts in the mouth or throat are actually quite unusual. They can occur, but are really quite uncommon for whatever reason. So it's estimated that in men alone, about 3 to 4 million cases of genital warts occur each year. The peak incidence rate for warts is actually a little bit older than it is in women. So as you can see here, this is actually in the second half of that decade in 25 to 29-year-old men. That may reflect, again, the wider distribution of HPV infection overall in men over multiple age groups. And again, prevalence of HPV, typically 20 to 25% in most young men. And as true with some other STIs, HIV-positive MSM have a much higher incidence and prevalence of HPV infection. So in some studies, most of these studies, it's showing 70, 80, 90% prevalence of HPV DNA, and particularly type 16 and 18. So that's why we're very concerned about anal cancers, particularly in men who have sex with men, because of that increased risk and increased risk of anal intraepithelial neoplasia. It is important to recognize that these cancers do occur in both heterosexual and homosexual MSM, regardless of their HIV status. It's just that if you have HIV infection, and this is true in women too, your risk of progression from benign HPV infection to a potential cancer or dysplasia is much, much higher. It's actually about 30-fold increase in risk if you're HIV positive. And that's true for cervical cancer, and it's true for anal cancer. HPV cancer in men is less common overall, although, as I mentioned, that seems to be growing, particularly for head and neck cancers. Men who have sex with men are disproportionately affected, particularly with anal infection, both anal warts and anal cancers. Some of the reasons for that are listed there, particularly the risk factors primarily for men having HPV-related cancer include being HIV positive, as I mentioned, and again, with a history of receptive anal sex. Here are some of the statistical associations with HPV infection, anal HPV infection, and the risk for cancer. I will mention that these things are, again, very, very similar to what they are in women. So high-risk sexual practice specifically refers to receptive anal intercourse here. Smoking, tobacco use has a 2 to 3-fold increase in risk. Being in other chronic immunosuppressive states, including HIV infection, is a very, very significant risk factor for progression, again, from benign HPV or self-limiting HPV infection to cancer. HPV transmission, just to review, the virus is transmitted almost exclusively through skin-to-skin contact, usually involving some degree of trauma or abrasion or friction, particularly sexual intercourse and direct genital contact. Penile penetrative intercourse is not always physically necessary. You can, in some cases, transmit the virus through objects, sex toys, and so on. But the primary sites of exposure tend to be where genital skin comes together. So the shaft of the penis, the opening of the anus, and the opening of the vagina. In men, this is a study showing the overall distribution of body site location for HPV infection in men. Again, typically the penis is the most common place, but this is looking not for genital warts, but this is actually doing samples and looking for HPV DNA. In particular, the virus can even be found in semen, although it isn't going to be clear whether that was contaminated on through the urethra or it's the origin is in a prostate. But since the virus does have to infect an epithelial cell, it's probably not infecting semen natively. There are a whole host of things in multiple studies that have been identified as potential risk factors for HPV infection. Some are biologically based and others are behaviorally based, sexual practices in particular. And as we've mentioned before, particularly cigarette use and tobacco use is a major risk factor, particularly for progression of HPV and persistence of HPV infection. And the other thing I'd just like to point out here on the left side is the viral factor HPV type. Not all HPV virus types are the same. They don't all have the same outcome and same more sort of morbidity. And in particular, HPV type 16 is what I like to call the bad boy. HPV type 16 is probably the most pathogenic, if you want to think about that way. It has the most association with causing cancers. It's usually a worse subtype to have in most circumstances, even compared to some of the other high-risk types like 31, 35, and so on. So we don't really screen for HPV infection in men like we do in women. So there are no current guidelines in the U.S. from any sort of federal source, CDC or the U.S. Preventive Services Task Force, that call for screening men either visually or with a laboratory test. there in fact are no FDA cleared tests that actually detect HPV in men. The studies we've been talking about so far are all done in research settings and often using homegrown DNA tests for HPV rather than any commercial test. So there is no commercial test. If this is important, because I would see patients all the time who come in and say they want to get tested for HPV, just want to get that swab test done or a DNA test. That really is not commercially available. If you're in a setting where there's research going on for HPV, that would be one way to have that done, but typically it's not available. And at this point anyway, we do not recommend any specific screening for HPV-related disease, including anal cancers, penile cancers, or throat cancers. This has become a very, very common question as these diseases become more recognized and reported in the media, particularly throat cancer. At this point, there really is no way to screen people with the equivalent of a pap smear or any other routine screening or diagnostic test to look for early signs of HPV-related throat cancers or penile cancers. Now, for anal cancer, there are a number of investigators that are looking at the possibility of doing an anal pap smear. And an anal pap smear is basically a relatively simple thing to do. It does exist if you haven't heard about it. So although at this point I should be very clear in mentioning there is no recommendation that you should do this or that there's any sort of routine guidance for patients to get this versus not getting it. So at this point in time, the CDC says it may be considered for certain high-risk clients. It is very commonly done in HIV-positive persons who have a history of receptive anal intercourse, again because of that 30-fold increased risk for developing anal cancers in that population. So this is something that is done typically in an HIV care clinic, but at this point most of us would not recommend anal pap smears routinely for all MSM, for example. If you're in a setting that can do it, it's possible that you could screen men who are perhaps at risk, but it is certainly not something that is widely available or typically done in most settings. It really is sort of location dependent. This is more common on the East and West Coast. It is important that if you do attempt or do initiate an anal pap smear or AIN screening program, that you have the system and tools in place to manage those results. And that means you have to follow through with abnormal results and be able to do what is the equivalent of an anal colposcopy, which is called high-resolution anoscopy. That requires a specialized training. It requires a colposcope and typically the ability as well to do biopsy. The management of abnormal anal pap smears and their treatment is sort of undecided. There are different approaches. There is no consistency at this point or guidance about how to manage those in the way that we manage abnormal cervical cytology. So really the message here is that it's possible to do anal pap smears, but it's really something that at this point should only be done by experts or people with experience both performing the test and managing the results. It is important to mention here, though, there is a current study that's ongoing to answer those questions. At this point, it's enrolling HIV-positive persons, primarily MSM, and it will sort of hopefully give us some guidance about how to perform and management of results and implementing treatment the same way we sort of have those standards for cervical cytology now. So that's something that's on the horizon, certainly something to think about. I think when that happens, you should be prepared to do it. The process for doing a anal pap smear is actually fairly simple. You just use a moistened cotton swab, a Dacron swab, excuse me, and submit it in a liquid-based cytology system such as ThinPrep. And assuming your cytology lab is willing to do it. But the process is basically the same for looking at the cells as with cervical specimens. A number of investigators have looked at the possibility of other ways of collecting this rather than a clinic visit, including what sort of is potentially of some interest here is the self-collected test, which may be coming in the future. But again, right now we don't really have any real way to manage or predict who gets tested, how often should they be screened, all those sort of things are up in the air. All right, well, let's move on and talk about the vaccines. It is still plural vaccines. There are 3 HPV vaccines licensed for use in the United States. The bivalent vaccine from GSK, the brand name is Cervarix, is no longer being sold for retail or in clinical use for the most part. So it's really off the market in the sense of that nobody in the United States is really using it. That, of course, is only a bivalent vaccine, and it is actually not indicated for males. The quadrivalent vaccine from Merck, Gardasil, has largely been replaced by the 9-valent vaccine. Eventually Merck will probably discontinue production of the quadrivalent vaccine if that hasn't already happened. And virtually by this point in the year, since it's been available, I believe, about a year and a half now, the 9-valent vaccine is primarily the vaccine that most of you are probably using at this point, and all of us should be using. So both the quadrivalent and the 9-valent vaccine are indicated and approved for use in males in the same age range, which is 9 through 26 years of age. And it's important to recognize that you really can use either of these. Going back to an earlier slide, if you remember, the additional 5 types that are included in the 9-valent vaccine primarily are protecting against cervical cancer. So one of the approaches, if you still have quadrivalent vaccine in stock, is it may make a lot of sense to use that up by providing the quadrivalent vaccine to your male patients and the 9-valent vaccine to your female patients as one approach. If you do not have quadrivalent vaccine, you really should just stick with the 9-valent vaccine. And again, these are the approved ages for the vaccine is approved by the FDA. That means anybody between the ages of 9 and 26 can get the vaccine. That's different from what is recommended for who should get the vaccine, which is a recommendation that comes out of the CDC's Advisory Committee on Immunization Practices. And this is the ACIP recommendations for who should get the vaccine. The FDA approval is for who may get the vaccine. And that's sort of an important distinction when we get to this sort of split recommendation from ACIP about men. So the routine age to immunize boys is at age 11 or 12, but you can start as young as 9. And locally, our pediatric practice here at UW-Madison is coming up with a new promotional gimmick for their providers called 9 at 9, and start talking to parents if they see a 9 or 10-year-old and get them with immunized with 9-valent vaccine as young as 9 years old. But the routine immunization age in the United States is recommended is 11 or 12 years old. And that is the age sort of that everybody should be getting the vaccine. And frankly, if we had really good coverage and compliance with that, we wouldn't be having this talk today because everybody would be immunized and there really wouldn't be any particular discrepancies or issues with MSM versus non-MSM or transgender versus any other group in terms of who's having problems with HPV and who's being vaccinated. So for older boys who did not get it at age 12, the recommendation is routinely to give it to all men through age 21 if they were not vaccinated at a younger age. For MSM men, if they identify as MSM or you take your sexual history and get that information, they should get the vaccine through age 26. And so this is this sort of split recommendation from ACIP in that if they're not MSM and they're over age 21, they may get the vaccine. That's an elective, it's a category B recommendation, so that means it should still be covered by insurance. If they are MSM though, they should be vaccinated. And frankly, the best way I can explain this and what we recommend our patients is that we say, at least at our student health service, and my personal recommendation is all boys and men should get the vaccine through age 26, independent of any of these sort of factors, whether they're MSM or not MSM. And of course, many young boys aren't going to identify or have not come out yet, so that's sort of, again, a moot point. If we immunized everybody at age 12, it wouldn't really be an issue. But it's really important that to understand the optimal time is to get the HPV vaccine is prior to any sexual exposure. That's really one of the main goals of giving this age 12. But the other important goal is that this vaccine just works a lot better if you give it in adolescence than if you give it to an adult. Every year you delay giving HPV vaccine, the immune response, the geometric mean titer produced, drops about 10 to 12%. So giving it at age 12 gives you a much stronger immune response than age 15 versus age 18 versus age 22. And I really would argue this is a more important factor than any other reason why you should give the vaccine well before age 15, is that it generates a much, much stronger immune response, and probably that equates to a longer duration of protection. The immune response needed to protect against disease is not really well known. We don't really know how much titer you have to produce with the vaccine to be protected. I think that most of these people who are immunized at over age 22 are probably protected just fine, but it may not last as long because the titer produced was smaller. This is updated vaccine coverage data for adolescents. This is from the CDC's National Immunization Survey of Teenagers. The latest data we are seeing in women and girls, it's sort of stalled. There have been a lot of improvements in men, but we are still a long ways from where we need to go. So basically what this tells us, if you look at the column for 2015 data, which is the most recent year the survey was done, about 2/3 of women, these would be adolescent girls aged 13 to 17, about 2/3 have received at least one dose of HPV vaccine, but sadly only 42% have completed the series and received all 3 doses. For men, of course, because the recommendation came later, the figures are worse, but they're actually just lagging in time for the most part. So among teenage boys, 50% have received 1 dose, and 28% have received 3 doses. So we have a huge, huge cohort of adolescents out there who have not received any HPV vaccine or are not current and complete on the series and potentially still at risk. One thing that happens if you only get 1 dose is you will develop some short-term protection that, say at age 12, that person is probably protected for a year or 2, but without booster doses, the 2nd and 3rd dose, that protection will likely wane, and by the time they become sexually active, they very well may not be protected anymore. So it's very, very important to complete that series. So let's talk a little bit about vaccination and MSM specifically. One thing that's kind of interesting in these studies, again, since 11 and 12-year-olds are usually not identified as MSM yet, most of these studies, as a caveat, have been done in older men who have been sexually active. And for that reason, the vaccine efficacy is a little bit lower than it is in women who are studied a little bit differently. So the efficacy against anal interepithelial neoplasia, or sort of the anal dysplasia, is a little bit lower, between 50 and 75% versus the 95 to 98% efficacy in women for cervical dysplasia. Even in someone who has a pre-existing HPV infection, immunizing them within a year of infection reduces the risk of developing, though, that anal interepithelial neoplasia. And as with women, if you can document that men who have no evidence of prior HPV infection against the vaccine types, efficacy is much, much higher, as you would expect. Among a survey of MSM done in 2011, very few at that point had been immunized against HPV. And this is sort of baseline coverage, because the recommendation for men to get HPV vaccine did not happen until 2011. The vaccine was only approved by FDA for use in men in 2009, so this is really baseline data. The very first year the vaccine was essentially recommended for men. And you're seeing very, very low uptake rates there among MSM and some of the factors that influence their decision to get vaccine, but hopefully this has improved since then. There are some very significant racial and ethnic disparities in HPV vaccine in terms of who is getting vaccine. So again, those figures I showed you before for adolescents, those are national averages. The 50% of women who've received, 42% of women who've received 3 doses and 28% of men who've received 3 doses. But if you look at subgroups, and particularly for African American males, the numbers are actually much, much lower than that. There are also significant geographic differences state by state. So there are states that have high compliance and much higher uptake. Rhode Island in particular, because it's a HPV vaccine, is actually a mandated immunization there, has very, very good rates. Talking to parents is sort of an important thing to consider as you're addressing this issue. If you're in a pediatric practice particularly, this is some survey data showing about what parents thought about the ability and the interest in giving the vaccine. And the major thing that came out of this study is that without a specific healthcare provider recommendation, they were more likely to not immunize their child. The single most important factor for immunizing a child, especially for males, was a healthcare provider saying you should do this. So I really implore all of you, when you work with parents, you work with males, particularly to make that recommendation directly. This is not a vaccine that you tell someone that it's elective or that you really can just think about it, but really, particularly for adolescents, they need to be told to get this. Here are some suggestions and tips for talking to parents about HPV vaccines, some of the words you can actually use. Again, you can download this from the handout if you want. We really now have moved to emphasizing HPV vaccine as a cancer vaccine rather than as an STI vaccine, particularly when you're giving it to 12-year-olds. It doesn't really matter what their future sexual behavior is going to be or their sexual orientation or their gender identity. It just is largely irrelevant. All 12-year-olds should be immunized against this vaccine. Because this disease is really so ubiquitous and most people, at least in the pre-vaccine era, the figure that's often quoted is roughly 80% of the U.S. population would eventually become infected with HPV if they were not immunized. So it's a very, very common virus that everybody's going to get sooner or later. Here's another 4 tips to talk about, and again emphasizing this is a cancer vaccine and something that everybody should be getting, especially now that the vaccine has been on the market and being used for 10 years, more than 10 years now, including the clinical trials. Very, very safe vaccine, one of the most efficacious vaccines ever developed in the United States, and that's a very important thing to think about. So this actually, in the data, this vaccine is as or more effective than measles vaccine. There are very few vaccines that can achieve 95% efficacy. This is one of them. And the methodology of producing the vaccine and in clinical follow-up studies have been shown extremely safe to use. The primary side effect is pain on injection site and a sore arm. There are essentially no serious adverse reactions associated with the vaccine. We've talked about this a little bit already. It's important to immunize before, ideally before any HPV exposure, particularly in early adolescence. So to answer a couple of questions, especially regarding the new vaccine, does HPV require any boosters? So as most of you probably know, this is a series of 3 injections given over 6 months. There are a lot of people who get off of that schedule, and so the most common question we would get, particularly from patients, is, do I have to start over? And the answer is always no. You just pick up where you left off. So if you received 1 dose or 2 doses and then stopped, 3 years later the patient comes into the clinic and says, I never got that 3rd dose, you just go ahead and give it to them right then. That is basically a booster dose which will get them covered long term. The other question that comes up now, particularly with the 9-valent vaccine, is do people need to start over again? If they received 3 doses of the quadrivalent vaccine, should they be getting the 9-valent vaccine? Currently, the ACIP does not recommend that you do that. There probably is little benefit to be gained in that person by adding those additional 5 types for the cost involved. And so at this point, there is no recommendation that you get a 2nd series with the 9-valent. The 3rd question that comes up, if you started with quadrivalent, can you finish with 9-valent? Absolutely, you don't start over. So if a person got 1 dose of quadrivalent vaccine and now they come in for their 2nd dose and all you have in your refrigerator is 9-valent, then 9-valent is what they get. That person probably will end up then with only 2 doses of 9-valent and 1 dose of quadrivalent. They may be slightly less protected against those additional 5 types than someone who got all 3 doses. And let's close with a case study, just a typical patient that I would see in my practice in a college health service. So this is a 22-year-old male who's coming in for his very first STD screening. He's already a senior. He's been sexually active since adolescent. But for some reason, after multiple physician and other healthcare provider visits in his life, has never been screened for STIs, probably because no one ever took a sexual history. But he has, he's seen the recent promotional campaign for the Get Yourself Tested efforts that the college participated in. He's asymptomatic, has never been tested before, and wants complete STD screening. So, what are some of the critical questions you'd really want to ask him as part of his medical and sexual history? So there are a number of things you can do in a sexual history, but here are the 5 things that I think in this case and with most of patients in this situation that are really the key things to zero in on that you really need to know to do the right screening for STI and to provide the right advice about sexual health. What are the gender of his sexual partners? And then has he, with those partners, if he says male partners, then you want to know if he's had receptive anal sex. You should never assume that all MSM have had anal sex. Many gay men do not have receptive anal sex, or they have only insertive anal sex, or they will have only oral sex. So you have to ask the specific question about what types of sexual behaviors and practices someone has had. You always want to ask someone if they've had any exposure to an STD, because for things like gonorrhea, chlamydia, and syphilis, you always want to treat them empirically for that exposure. If it occurred recently, you want to be asking every patient really if they've been vaccinated for HPV. In the ideal world, I think you would do this in every primary care setting at every visit, especially with a new patient. You'd get a complete vaccine history. But particularly in a sexual health or reproductive health setting, assessing for HPV vaccination history is extremely important. And then you always want to ask about condoms and how often he may be using them. So is HPV vaccine indicated for this guy? Absolutely. He is over the age of 21, but he's MSM, so he automatically becomes part of that subgroup that ACIP says yes. Provide him with 3 doses, in this case with a 9-valent HPV vaccine. So just as a review, the sexual risk assessment or sexual history, these are the 5 Ps. A number of groups, including CDC, have formulated these recommendations in a number of different ways. Really very, very useful things to remember. What to ask people about. If you can't think of everything, sort of just focus on these 5 topics. In summary, HPV and MSM in particular, MSM who are HIV positive have a 30-fold increased risk of HPV infection and cancer. Men with other immunosuppressive conditions are far more likely to develop cancers at any site, but particularly anal cancers from HPV. MSM are interested in doing anal pap screening once that sort of becomes a possibility. Most importantly, HPV vaccine is indicated and recommended in MSM through age 26. And even after initiation of anal sex, HPV vaccination is a benefit. All right, we're going to stop here and take your questions, and I'll turn it back to Jessica to manage that, and then following questions we'll wrap up with, again, a summary slide.
Great. Thank you so much, Craig, for that excellent presentation. Our first question comes from Dr. Asma, who asks, if a sex worker male comes into your clinic to be screened for HPV, which one do you recommend?
Well, to be screened for HPV, there is no specific screening test for HPV. So at this point, regardless of their sexual history or other risk factors, there is no screening recommended routinely for HPV. By screening, I mean a diagnostic test in an asymptomatic person, if that was the question.
Yes, it does look like it's the question. If that isn't clear, Dr. Asma, please feel free to follow up. Oh, right. Sorry.
And if that person is under the age of 27 and they have not been immunized, then you would provide them with the appropriate doses of vaccine. Another question that comes up quite often while I'm thinking about it is what if they're 27 or 28? Should they maybe still get the vaccine? That would be an off-label use of the vaccine. Many providers will provide the vaccine to those patients in those circumstances, particularly if they're at increased risk or you assess them to be at increased risk for HPV infection, or if the patient is requesting it. So we've done this for many college students, graduate students, and professional students early on when the vaccine came on the market who were over the age of 26 but really wanted the vaccine. There's no reason, there's no safety reason you can't do it. There's very little data about efficacy as you get older, but there's no reason you can't do it. The caveat would be that insurance may not pay for it. So many insurance plans will not pay for vaccine past the age of 27.
Perfect, thank you. I believe that also answered our next question. So we'll move on to Shannon, who asked, during the STD history, we are to assess for receptive anal intercourse. What about a penetrative patient whose partner may have anal HPV? Did that make sense? I can read that again if you'd like.
Yeah, please.
Okay. So during the STD history, when you're assessing for receptive anal intercourse, are there any particular considerations for penetrative patients whose partners may have anal HPV?
Oh, okay. So in this situation, you're saying a patient you're seeing who's had insert of anal intercourse with a male partner who has known HPV infection. So you really don't do anything differently in terms of screening or testing. I would say in my approach in that patient is I would definitely do a genital exam and perhaps with a focus on looking for lesions. Generally, when someone comes in and tells me that they're exposed to an STD and exposed to HPV, that if they had a sexual partner with known HPV infection regardless of location, my physical exam, genital exam might be a little more thorough in terms of looking for lesions. But other than looking for lesions, there isn't really anything else you would do. So there is no diagnostic testing. You don't swab his penis for HPV virus or anything like that. You would do other STI testing as indicated, primarily in this patient if they've had insert of anal sex or insert of vaginal sex or insert of oral sex. It doesn't really matter. You screen for gonorrhea and chlamydia with a first void urine sample. And then again, for men who have sex with men and have had receptive anal sex, you would do rectal swabs for gonorrhea and chlamydia. And for all MSM, always do VDRL and HIV screening. So that's sort of the package of STI testing for MSM.
Great, thank you. Cindy has a related question. If receptive anal sex is such a factor, should we be performing anal paps on women as well?
Great question. Undecided, and just like it is with MSM, sort of an unknown data-free zone at this point. Again, many HIV practices do routinely do anal paps on both men and women who are HIV positive and have a history of receptive anal sex. The risk of anal cancers in women who are HIV positive is also very high. Particularly, something I didn't mention, but just in terms of numbers, it's been estimated that the current rate of anal cancer in MSM who are HIV positive is roughly equivalent to the rate of cervical cancer in women prior to the introduction and development of the pap smear. So a lot of people argue that we should be doing anal paps given that kind of prevalence of disease. I think the issue is, and the reason it's not so much controversial as it's not exactly the same disease, and the management of abnormal results is very much undecided, and different clinics and different providers have different approaches to how they would manage that. So I hope that answers the question. So yes, women who are HIV positive, in most HIV practices I know they are doing anal paps, but that's sort of a clinic-by-clinic decision as opposed to a national guideline.
Great, thank you. Margaret asks if you've heard that taking folic acid is helpful in clearing the virus.
I have not heard about that and don't know anything about it, so I won't comment further.
Sounds good. At this point, I'm not seeing any other questions. For folks that haven't asked any questions yet, make sure you look at the question box and enter your question in there. All right, Craig, it looks like we have answered everyone's questions so far. So would you like to review a few key takeaways for our participants?
Absolutely. So just to review, HPV is the most common STD in the United States, affecting nearly all sexually active people, although we think that those numbers are probably declining, at least in adolescence right now. But it's going to be a long time before it really gets to all of us. Of the roughly 31,000 cancers attributable to HPV, the vast majority of those are entirely preventable with the current 9-valent HPV vaccine. Anatomical history should be taken from all adults and adolescents regardless of their anatomical sexual history, regardless of their gender identity, orientation, or sexual practices. So you need to ask specifically about what sexual practices they've had so you know what to be concerned about, how to counsel them, and what to test for. There are important barriers to HPV information and provision among sexual and gender minorities, which can include cost, accessing health insurance coverage, confidentiality, stigmatization, and certainly we didn't really talk about this, but a lot of healthcare providers themselves are uncomfortable with patients who are not like themselves and often will not even address these issues or will not take a proper sexual history. Men who are immunocompromised, particularly with HIV infection, are far more likely to develop HPV-related cancers. That's also, again, true for women. The optimal time to get the HPV vaccine is both prior to HPV exposure and in early adolescence. HPV vaccine requires 3 injections over 6 months. No booster doses are currently recommended. You never start over. Just if you get off the schedule, you just pick up where you left off. We've provided a number of resources for you with additional information about HPV and some links to, particularly for care for sexual and gender minority patients and MSM.
Great, thank you, Craig. And thank you again for that excellent presentation, and thank you all for joining us. We would also like to thank GLAMA Health Professionals Advancing LGBT Equality for their partnership with this program. Before we end today's webinar, I'd like to share a few important reminders. Please note that this program was made possible through an independent education grant from Merck. In about an hour, you will receive an email from Caitlin Borsowitz containing a link to the post-test survey. Your CME or Nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions, just email us at education@arhp.org. A recording of today's webinar will be posted shortly on arhp.org. arhp.org is also where you can register for the next webinar in this series that Craig mentioned at the beginning. The next one is titled HPV and Sexual and Gender Minorities, and it takes place on October 3rd at 1 p.m. Eastern. So make sure that you're checking out ARHP's website frequently for updates and our upcoming webinars. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP. Take care and have a great day, everyone.